concerned about your accuracy, but we're talking about pointing out a point that's probably just under a millimeter and confirming it's in the exact same spot as it started. Automatic registration, the key to this is if we look at the left-hand side of the screen is that there are optical trackers actually in the scanning mechanism. So on this CT scanner, there are 5 little dots around the yellow ring, and those are optical trackers that will then be able to see the little registration tool both in my hand as well as connected to the patient, so the patient's registration tracker. Dr. Wonder has a couple papers looking at some of the CT or cone beam CT where they can improve some of their accuracy. And so they obviously improve this over kind of a manual registration or fiducial registration. And then even in the spine world, we've managed to show that there's also increased registration accuracy with using an automatic registration process versus a surface matching registration process. And so in this is my original CT scan. Patient scanned into the process. Because there is no need for fiducials and just the patient tracker has to be placed, that's all that needs to be done. And so if I wanted to, I could start my case based off of the CT already, but I chose to bring in a CT scan that I had planned before. And very similar to what Lee Jays had done, we kind of match these up so we can get things to line up for us. This is just an example. And then after that, you click on the automatic matching and it kind of fine tunes that. With some of the new software that they have, this is a MRI that we're now going to fuse to this patient's CT scan that was done intraoperatively. So this allows me to see some of the tumors a little bit better and see where we're at. Just a fusion image of patient tracker as well as the patient's tumor on the left side. And so the CT portion of that, and these are two fused together. And they can make it very easy to kind of appreciate where marrow margins may be an issue and allow you to stay out of those locations. Just an example, same patient, just a reconstruction of their pelvis that was able to be done with the CT. And now with cutting jigs out there, we also have, I guess, virtual cutting jigs. And so we can have the people that are planning our custom prostheses, they can provide us a virtual prostheses as well as a virtual cut, so everything sort of lines up. The benefit to kind of both cone beam and CT navigation, as long as you have preoperative imaging for the cone beam or 3D fluoroscopy unit. This will allow us to kind of cut in the appropriate location and again get the implant. So the biggest difference between cone beam CT and CT is may limit the ability to use intraoperative fluid if a dedicated bed is not completely radiolucent. So I have that problem with my Aero device. So there's times I'll end up using the 3D unit versus what they have in Toronto. They have the ability to always use fluoroscopy anytime they want. With this registration process, they have for automatic. However, they can't necessarily see the entire femur if they wanted to, unless they were able to scan all the way up, which a lot of times for devices, times I'll end up using the 3D move all the way up. So both take less time and there's smaller registration errors both in these systems. And so navigation assisted pelvic resection has been greatly aided in order to get negative margins. We can multiplanar cuts. We can use custom prostheses that are well matched to what we resected. And so we have a final product. We can even use it for joint sparing resections. And so I would point out one of the advantages of cone beam is the ability to see the limb and use it intraoperatively in order to get appropriate margins as well as to reconstruct the area. The downside to some of the cone beams in the past had been their field of view with the Arcadis. If you were going to use this on the extremity and not have a good preoperative CT, because of the way the CT scanner moves around the limb, unless it's centered on the bed, sometimes you can't get an appropriate view. Now with some of the cone beam and 3D fluoroscopy technology, you have a much wider field of view, and so that's less of an issue. And so we can easily do joint sparing. So CT versus 3D or cone beam CT fluoroscopy, automatic registration is best for both. That's what the studies are basically showing. The 3D fluoro unit, if you're going to want to see the entire compartment, oftentimes you require a preoperative CT, so you can fuse those together intraoperatively after you've marked things out. And that's because your markers or registration devices need to be present in the current scan to get it appropriately marked out. If fiducial is used, usually requires greater surface area to be exposed. So there's a benefit to just a CT alone, which typically you can scan a patient prior to even opening them just by placing a tracker, and your registration process is complete as long as it's used automatically. If you require fiducials, obviously you can't properly do a scan until after you've been able to put in the fiducials. Thank you.
Thanks, David. So, any questions on the chat? So we have Casey who's asking Lee. He's saying, can you think of any items that can be added to the existing Stryker OrthoMap 3D system to enhance the oncology application? You're
Can't hear you.
Mute.
You're on mute, Lee J.
Yeah, sorry. So I just talking back to me. So I think obviously adding the SCLs in for the implants and the jigs is useful. That's quite difficult at the moment, and the software upgrade how to do that. But the obvious next steps would be to use augmented reality to be able to see your plan on the patient, and maybe robots to do the angle of the cuts. The trouble is there's still an idiot, which is me, at the end of it, doing my own, either ignoring it or not ignoring it or getting it slightly wrong. So I think that's why the combination of jigs and stuff, but a robot would be obviously even more precise. And I know that several groups are working on that, which I think is pretty exciting. I was going to ask a question to David. So for the real world, UK is a third world country. There are some limitations to have an air LCT. They're expensive. They're heavy. So if aren't there some rules about what floor levels you can have them on and stuff like that? Have you?
And can't be moved.
And they can't be moved. Yeah. I mean, we would have no chance in getting one into our little Tin Pot hospital. But did you have to plan it very carefully, or in terms of business case, did you use the spines and neurosurgeons or whatever as brain surgeons?
So good question. So in the third world application, probably the 3D fluoroscopy units probably ends up being better because you can use it for multiple applications, and it allows you to do everything that I primarily do. You just have to have a pre-op scan so you can kind of fuse things together. So it works great. I mean, that's what I had before. Essentially, I had an Aero, and I have both. And the reason I have both is because there are limitations to the Aero. One, in the ability to change things on the fly. You're sort of stuck with a CT, and so it can be a little bit cumbersome at times. I would say that the CT is probably best for just doing the pelvis side of things because it provides you such an accurate image compared to just the fluoroscopy unit, even though they're getting bigger and bigger. But in a third world, I would choose probably a 3D fluoroscopy unit because it would be the jack of all trades to do things.
Can you rescan it when you've done your resection and see what your defect is and stuff like that?
For the CT scanner?
Yeah.
The CT scanner, yeah. And I oftentimes do that in case I'm planning for my failures in the future when the implants fail. So if I need to I can tell them what the resection was because I could send them that file to do that. And the one comment I would make is that, like you were saying, robots being helpful in the future, because yes, every once in a while I'm dumb and my cut's not quite at the right angle, and I don't quite understand why my brain's not registering that. But that's probably the biggest thing. I've used jigs in the past, but I've shown I try to navigate where the jig is placed because I feel like just with surface matching it doesn't quite all line up, and you can't get a jig to sit quite exactly where you want. And so those are my things. But, for people trying to get the system into their place, probably a 3D fluoroscopy unit is the better way to go.
David, what about portable CT? That
So
could solve
technically
Lee's problem.
Yes. So technically the arrow does move. And so they can move it. And so we had talked about how do we justify doing this? And at times, and I'm not advertising for the arrow, but this is the discussion was being able to use the arrow in the ICU unit after hours. Because oftentimes they're needing to get a whole bunch of CT scans done at night. These people are having problems and people are backed up. But if you have a CT scanner that can be mobilized, as long as, again, as Lee pointed out, that it can get to a certain floor based off of its weight limit, that is an option to do or how to present that to somebody.
Okay, we'll move on to Jay.
Hey, David. So yeah, that's a cool technique with the screws. There's a guy in Korea, Hwan Sung Cho, who sort of described he was doing that. Like he would put a screw in the patient pre-op the day before and then get a CT scan,
Right.
and that's how they sort of did it. But so I guess when you expose the whole pelvis, it's no problem putting those little screws in. But if you're doing it in an extremity or in a diaphyseal bone, is that a problem with the screws? And does that get in the way or does it leave holes in the bone?
Yeah. So it depends on how, the important thing is getting the appropriate surface area and enough exposure that you can put screws far enough away that you can make your registration accurate.
Right.
And so looking at what you've done for how things are there, it's almost like the screws are external. And again, you have an optical tracker to sort of match some of those things. You don't need the true fiducial screws if you have an automatic registration because you have optical trackers on the scanner themselves, because that's how it gets things in space. It's not relative to the scan that was done in the patient tracker in the fiducials, because that's how the manual registration would work. It's just based off of the tracker and the optical tracker on the actual imaging system. So, but there are different ways to do that. But, I hated manual fiducials mostly because of the registration error. And so I was always trying to find something smaller to help myself be more accurate. And I definitely, having them in certain appropriate planes to do that makes it more accurate. So that way, when you're trying to scan through by going cut by cut, you eventually run into it that first time. And that should be the first time that you touch off on that point.
Interesting. Thanks.
Okay, so we'll now move over to Jay and Peter, who are going to talk to us about their own navigation system that they have developed, as well as some uses of jigs.
Okay. Can you guys see that? The slide okay?
Yeah.
Yes.
Hi. So I'm here with my partner Peter Ferguson from Toronto, and we're going to provide our perspectives on navigation and also on cutting jigs.
Jay, can you put it to the full screen?
You put on presentation mode.
I did.
Do you have two screens up on your computer?
Yeah. I don't know. Yeah.
Share your other screen if you have two screens.
Is it not on presentation mode now?
No.
It is, but
No,
we're
because-
seeing your next slide.
Yeah.
I don't know how to get rid of that.
Do you have two screens?
Display
or two
settings.
Separate
Go in-
monitors?
Yeah.
If you have two separate monitors, share the
Just a
other
mirror.
monitor.
Okay. Stop sharing. I don't know. Only one is coming up.
Let me try from mine.
Okay, do you want to try it?
Yeah.
So while they're setting it up, Lee, one question for you was, you said that the camera of the navigation was behind the surgeon.
Behind the patient, in front, facing the surgeon.
Yeah, but can you have it at the foot end where it doesn't get obstructed by any of the surgeons coming in the way?
You can do. One of the things that people don't talk about is being clever at the beginning and working out where the optimal position for your patient tracker is. You got to remember that we're in a floppy lateral, so we're rolling them front and back, and sometimes sort of side to side. So you want to make sure that's why it's in the middle of those two circles at the beginning. We tend to find it works because we only do it in the pelvis. That it sort of works best when it's about 6 feet away from you, looking at the surgeon.
Yeah, go ahead, Jay.
Okay now?
Okay, is that okay now?
Yes.
So yeah, we're going to just provide our sort of perspective. We were pretty lucky. We started working on this in-house system about 10 years ago with our colleagues in ENT, head and neck oncology, because they had similar issues with margins, and we developed an in-house navigation system together with a group of engineers that sort of gave opportunities for both of our groups in terms of more precise and accurate margins. And initially, just go back one, Pete. Initially, it was built on this robotic arm cone beam CT scan that we used across the street at the hospital across the street from us. And when I was chief of surgery and we were building new ORs, we convinced, because we're the reference sarcoma center, we convinced the hospital and a donor that we should have a cone beam CT in the OR for sarcoma. And we now have a mobile cone beam CT scanner. So it's fluoro and CT, cone beam CT, but it's mobile. It can move in and out of the OR field. This one that you see right here moves on a robotic arm. The other one just moves in and out on wheels. But it's otherwise set up with infrared camera but the big thing is that we have our own navigation software. So if you just go next one. So basically there's a tracker that goes in the skin, and what we published, I guess 2 years ago, was this automatic navigation system. But unlike what David was showing, there's nothing, we don't have to put anything in the bone. And what we do is we just put these markers. Initially, we just put these markers on the skin, and so here's the tracker in the bone, and then we put the markers in the skin, and we do our spin with the CT scan, and it registers the markers on the skin with the reference marker, and it links it to the pre-op fused CT and MRI, and it provides really accurate. This system that the engineers developed provides very, very accurate registration. We had used the Biomet system and the Stryker system before, and we found that there was a lot of error. And although that system tells you there's not a lot of error, often there is more error than you think in reality. Okay, so we can go next one. So we just had a fellow, Liu Zhang from Tokyo, and he worked with the engineers. And now what we have is the marker, instead of being on the skin, it's attached to the rigid marker with a rigid arm. And basically, it just makes the whole process much more accurate, because we found even though these were taped onto the skin and then we would do our CT spin, there was always micro motion, it seemed, when we would put the bag over the patient to like make everything sterile. And now with this markers on a rigid arm, we just basically attach it to the arm, do the spin, and then we take these markers off so they're completely out of the way. And it helped shorten the registration time, and it made our registration very accurate without doing any surface mapping or point pair mapping. And that's the big thing. Now, this is an in-house system, and I'll just show you a little bit about the software. But the one thing about it is so far it's still very engineer dependent. It's almost like it's the beta phase. And so to get the whole system to work, there has to be an engineer in the room who does the background work. So it's not, I'm at the point where it's automated and anybody could use it yet, but that's what we're hoping for, like you guys have with the other systems. Okay, next one. And so again, this is how we used to set it up with the markers on the skin, but now the markers are attached to a rigid rod. Okay. And this is a color map, and this is looking at the, it's comparing basically how accurate the registration is if you do pair point registration or if you do our automatic registration. And the color basically shows like green is accuracy within a millimeter, and you can see the scale here. So if you do pair point registration, it's very accurate right where you pick your spots or right in the middle. But as you go away from the center that you're interested in, the accuracy goes down a lot. But the systems don't actually tell you that. But when you do this automatic registration, it's basically the entire field of view is accurate within a millimeter. So it's a really amazing system that the engineers have thought up how this works. Okay. And the one thing that you'll see with this is that so we can fuse the MRI and CT pre-op and link it to the cone beam CT scan in the OR, and we can track the anything. We can track a blade, or we can track an osteotome, or we can track a burr. But the thing is, you can actually see it in real time, and you can see it where it goes in. You can see the pitch, you can see the roll, you can see where it comes out, and you can see where it's going relative to the tumor. Okay. So this is just an example. This is a case that we did in the lab. So this was actually a 3D simulation model that we did using a patient case of a parosteal osteosarcoma that invaded into the bone. And the blue lines are basically the pre-op computerized planning. And the dark brown is the tumor, and the light brown or the chicken wire is sort of the 5 millimeter margin. Okay, next. And so the purple is basically the osteotome. And the problem is the osteotome is on the red line. So we know it's starting at the right point, but we don't know where it's exactly coming out. So our navigation has this cue system that shows up on the screen, and it shows you the distance from the starting point, the pitch, and the roll. And if all three of these are green, you know that your osteotome's angled in the exact right plane. And if one of them is red, like this one, it means the pitch is off. So it means somewhere you're not angling in the right place. So like this osteotome, we don't know if it's going too far away or too close to the tumor. Next one. But if we change the angle of the osteotome, now it's 3 green bars. So it gives you a visual cue that tells you you're aiming exactly in the right position based on your pre-op plan to miss the tumor and have the right margin. And then the next one. So the other thing our software does is we can do this clipping plane where we can take away half of the bone, so we can actually see where the osteotome is going. And now we see the red line all the way through the bone, and we can see that we're actually too close to the tumor. So next one. So now we just change the osteotome. Now we can see the osteotome is going along the red line, which is basically the preoperative CT cutting plane. We have 3 green lines, and so now you can cut. And you know you're going to go in the right place, come out the right place, and you're going to miss the tumor. So it's just one of the novel features of this navigation software. Okay. The other thing we did is, we all work with a lot of trainees, and so a lot of trainees, we're sitting there basically telling them how to do the operation. They sort of think they're doing it, but really we're doing it. And this basically looked at a bunch of different surgeons with different levels of experience. The only surgeons who had used the system before were the 3 of us, Peter, Kim, and I. But we looked at other staff, ortho surgeons, surgical fellows, residents, and we basically all gave them a simulated model in the lab and just taught them in 5 minutes how to use navigation. And we looked at how accurate they were in terms of their entry into the bone, the pitch and the roll using navigation, cutting out a simulated tumor. And the residents were as good as we were. So it does show you that if you follow the simple rules, once it's all set up, anybody can actually cut the tumor out. Now, obviously, like Lee said, it's all about getting to the tumor and setting it all up. But for the actual cutting out the tumor, you can involve anybody, and they can probably do the cuts pretty accurately. Okay. So some of the potential benefits of this system with auto registration are you don't have to expose as much bone because you don't have to do pair point or surface mapping because we have this auto registration. So it is very helpful. It's really reliable for patients where there's no unique landmarks, like along the mid shaft. I'm going to show you a problem with jigs where that was an issue. And also when there's a really big soft tissue mass, or sometimes once you've done your soft tissue resection, and you think, well, can I use a jig? You actually can't fit a jig on because the tumor is massive or the soft tissue mass is too big, and there's no room to actually get to where you want to go. So sometimes this can be very helpful in those situations where you're really limited. Okay, next. So to get Manish asked us to talk about jigs, and Peter's going to show a few cases, but we just published this study in CORE. So it's really comparing handheld tumor resection versus cutting jigs versus navigation. And this wasn't an in vivo study. This was a study in the lab where we basically made a simulated tumor using a parosteal osteosarcoma, and we have a computer-generated defect. And instead of using the navigation to cut out the tumor here, we basically said to the different surgeons, here's a defect, here's an allograft, cut the allograft to fit the tumor defect. So it's actually the same thing, like trying to make an accurate cut. So each of the surgeons had to make a freehand cut of an allograft to fit this standardized defect. We made up a jig for them and we showed them how to use it so they could use a cutting jig, and then they had to use a navigation system. Then we looked at the outcomes of this. Okay. So this is using this thing called a Nassau Mental Task Load Index. And it's a validated tool that assesses mental workload, and you can see the different scales. And there was really no significant difference from over most of the scales between using the three, except in performance. And performance was an overall measure of how well the task went. That was basically, again, assessed by the actual individual surgeon. The only difference here was that the freehand they found was harder than using the navigation, but that difference was actually very small. Okay, next. And then we were interested in how well could they cut out the allograft to fit into that standardized defect. And it took longer to use the navigation, but there was no statistical difference. This is a color map that looks at how accurate the allografts were that fit into the defect. Red means there's inaccuracies, and green means there's accuracies. So the navigated allografts fit the best. You would think that the PSIs maybe would have been as good. They were a little bit off, not quite as good, a bit of red. And then obviously the handheld ones, there was a lot more red, so there was a lot more inaccuracy. Okay, next. And then there were basically 21, in the study, there were 21 allografts that were shaped. And then there were blinded reviewers who had to assess the fit. And basically the navigation was better than the PSI, and then both of those were a lot better than the freehand. So the PSI navigation aren't that dissimilar in terms of how well they work, but this was in a model in a lab, right? No soft tissues, and we all know that that's often the issue in terms of how one of these works better than not. But the navigation and PSI are relatively similar in their accuracy. Okay, next. Okay. So Pete?
Yeah, so for the last few minutes, I'm just going to show a few cases that I think demonstrate the advantages of this system. No one system is going to work in every clinical situation. There are situations where jigs don't work effectively, or the conventional systems don't work. So here's some illustrative cases that I think demonstrate the advantage of this particular system. So this is a big surface chondrosarcoma of the proximal femur, and the challenge here is that with this huge soft tissue mass, it can be challenging to get a jig on over this long distance. Furthermore, because it's a cylindrical bone, it may be difficult to identify areas for accurate paired point registration, and the jig may not fit on accurately, as David had suggested, in that cylindrical portion of the femur. So our system was used quite effectively here. Patient had an intramedullary nail put in first of all, and then the tracker was attached quite distal in the femur, sort of out of the sort of field of view of the tumor. But with that bridge, the trackers were extended, quite close to the surgical field. They could be visualized on the cone beam CT, and then accurate osteotomy was done around the nail, and an allograft was put in place. And that healed up well. So that was quite an effective use of this system in this challenging case. Here's another secondary chondrosarcoma arising from the spira pubic ramus. Small field of view because the vessels are close by, abdominal wall musculature, and that could make it challenging to do, again, paired point registration or surface matching. And so in this situation, the tracker could be put outside the field. On the ASIS, for example, the bridge could be extended down into the field and accurately utilized to navigate the sort of challenging osteotomy angle here, such as done right there. Here's a big secondary chondrosarcoma arising from the iliac wing. A couple challenges here. One, because the mass is so big, it's difficult to get the exposure to be able to get a jig on, and similarly to do accurate paired point registration because of that overlying soft tissue mass. So we could utilize our system with that bridge. Again, once extending down into the field, the tracker could be placed in the bone remote from the tumor there. And here's an example of our fellow utilizing one of our navigated tools. This is a navigated oscillating saw, which can be used then to accurately complete that osteotomy as shown. We have started using some cutting jigs here. Here's a case of Kim's, this chondrosarcoma arising just superior to the articular surface of the distal femur, and that was successfully osteotomized using an accurate cutting jig. Can also be utilized. This is the next case, but it can also be utilized as Jay mentioned, to accurately cut allograft for structural reconstruction. And here's a case here of a surface chondrosarcoma of the posterior proximal tibia, big soft tissue mass overlying the majority of the posterior tibia. Once again, difficult to find accurate spots to be able to do pair point registration. And even then found it would potentially be challenging to be able to put our marker on or our tracker on in an area remote from the tumor without compromising the integrity of the tibia. So utilized cutting jigs in this situation, got a very accurate osteotomy with limited exposure, and we're able to osteotomize an allograft using the same cutting jig. It fit in perfectly and was able to be fixed in place, and the patient healed well. And then finally, this is a patient with a metastatic sclerosing epithelioid fibrosarcoma of the tibia. The challenge here with the cutting jig is that because it's on the cylindrical portion of the bone, it's very difficult to accurately gauge where you are when placing the cutting jig. And when it was put on in this situation, found out they were 1 centimeter off from the expected location. And so that had to be adjusted and accommodated for using navigation. The osteotomy was completed, just maintaining that anterior cortex, and then an allograft was put in place. So I think these are some good cases that demonstrate sort of the complementary nature of not only this system of navigation, but also cutting jigs, and understand that there's not a one-size-fits-all approach to these complex osteotomies. So there's the take-home messages that we've sort of emphasized in the last little bit here. That the cone beam system is quite useful, and we've been able to now get the additional time down to somewhere around between 20 and 30 minutes. Auto registration, we are firm supporters of this, that it really minimizes your target registration error and decreases the amount of exposure that you need to get otherwise in paired point registrations. These cutting jigs can be quite effective in some cases, but I think it's reasonable to have a complementary approach where you can confirm your location using navigation. And that's it.
Thanks, Peter. Great cases. Now we have some questions in the chat box. Amar Kamath has asked David about what's the learning curve in using this automatic registration. Is it as much as what you have with manual registration, or it's much simpler?
It's much simpler, because all it is putting a patient tracker on and then scanning the entire compartment. And then that's with the CT. If you're using 3D fluoroscopy, so like say for a femur or something, the patient tracker goes on, the tracker has to be in the scan field. The optical things on the 3D fluoroscopy and have to be able to see that. And so in order to see the entire compartment, all you do is have just the intraoperative image to the preoperative CT or MRI, and then it's complete. And so there's less fiddle factor, less time component involved in it, and less tissue has to be exposed.
So you would need a technician to interop to do the fusion, isn't it?
I don't usually. So the work process for me is usually I end up doing most of it. If I don't do it, then I don't understand why the system fails. And I've had a few times where there's a software issue, like a preoperative CT. So one of the things that people never really point out, but there's a specific protocol for these CTs and MRIs. And while it may look correct, if it's not organized in the appropriate data information, like there's not a data set for each line that needs to be there, the navigation system will go forward until you try to do like some extra little things to refine it, like with surface matching or something, and then it'll crash. And you won't understand why it crashes, because it was working, and then as soon as you try to improve the refinement, it crashes. And so I've seen that, and that comes down to the basic code that's there. So it's important to have a CT scan that's perform preoperatively the correct way. And so, yeah, you can, it's pretty easy, but it definitely takes me about a good 20 to technically 30 minutes to do fiducials, because the process of me putting the fiducials, scanning the patient, then marking out my fiducials on the imaging system, then going back and then matching those points with my tracker, it takes that amount of time. So that's with a fiducial, but it works well. I get a good, my registration error is less than 1 millimeter, and it works. And that's why I said is like automatic versus manual registration. They're both good. One is better, but I still like the manual registration as well, in the times that, I necessarily need it. And that's what I've sort of had to gone through, because I switched over my navigation system recently, and I'm waiting for a software update to be approved by the FDA, for my current navigation system, so I can get back to an Ortho 3D map for an automatic registration for the 3D fluoroscopy unit. So I get to do that all over again and remember all the fun it was.
So we have a question from Casey Wong to all the speakers. He's asking any advice how to choose between navigation, guides, or both in bone sarcoma resections. What are the factors you consider in choosing the type of tools for your case?
Well, I think Jay and Pete made very good observations. So look, hands up, I only really use navigation for the limb cases that we've done. And of course, you've got loads of points there for your points and stuff like that. I think the point Pete and Jay raised is that if you've got a big soft tissue mass, then it can be quite hard to get a jig on, and the thing is the engineers only are looking, and they don't always appreciate it very hard. So sometimes you find they'll make a jig on the inside of the pelvis or something like that, or the lines of approach aren't the right thing because they haven't got proximal femur on their plan. The other thing is big problem for both point-to-point registration, as I said, is the diaphysis of a bone. It's a big cylindrical tube, so there aren't any points to take, So using navigation and jigs in the pelvis, we tend to use that when it's associated with a custom made. So because that's where the engineers want. But we'll use navigation to check that the jigs are in the right place if we can fit them on. I think jigs work very well in the bones, especially if you associate it with an allograft, because you can make 2 jigs. And Luis Aponte made a very good point that you should make your jigs for the allograft a little bit bigger, because you lose a little bit at 2 millimeters with the saw blade. And then it comes down to how much you're doing it. Navigation with manual can be quite complicated if you're not doing it all the time. We're doing it once a week, so we know all the limitations of the system. If you're trying to bring it in for the one difficult case a year, then that's going to be a problem for you.
We have a question from Philip Jurovics from Austria to all the speakers. Of any research going on for integrating fluorescence into established navigation systems to facilitate the soft tissue handling?
So I've used it once, I would say once, for a melanocytic schwannoma in the front of the sacrum, because those are typically they're pretty rare, but they can be malignant. And when we were I used navigation because I thought I was going to have a hard time finding where that little nodule was, because it was only a couple of millimeters, and I was able to use, as long as the tissues don't move, I was able to find that very specific area on the nerve and remove it and know that that was it. Otherwise, looking at it physically, I couldn't really tell. As far as, do they help with soft tissue management and everything? The automatic registration for me definitely helps out, because I tend to do less of a surgical exposure. And so I can actually make some some small windows just to make a fine cut in certain little areas where normally I would have had to expose the entire thing in those locations, because I don't require the surface area to use fiducial or surface matching to register the patient.
So I think the big problem with soft tissues is soft tissues move, don't they? And if you think about what we do, we basically undo an envelope and move everything out of an anatomical plane, and that makes navigation very difficult with soft tissues. There's a study with immunofluorescence starting in the UK, sarcocyte study in a few months' time. Whether that will show its benefit or not, I think is still open to question. But combining the two is very difficult at the moment. That may be a better role for augmented reality than navigation itself, you know.
Dr. New has put in two questions, and the first one is it simpler and more accurate to obtain staged allogenic bone in the same way as resecting staged tumors? And his second question is it is only necessary to use the CT data of tumor removal to re-register on the allogenic bone?
Yeah, so I guess in terms of using, like, we were using navigation in the extremity, you can apply the same pre-op plan to the allograft to make those cuts. That you saw those last two cases with the jigs. It's actually, if you can make a jig fit in the extremity for multiplanar geometric, limb sparing for osteotomy, it's pretty easy to just make the same jig but slightly small, a few millimeters bigger, to cut the allograft. But you can do it either way. So I think one of the points is it depends what you have available. Like, there's no question that we were very lucky to be able to set up this cone beam OR room, because I was a chief of surgery. We were building new ORs. We were a big sarcoma center, but it costs a lot to do that, right? And there's a big cost to the ongoing development of the system for us. But luckily, we had a donor who's supporting this. If you don't have that available and it's hard to get in the system, well, cutting jigs is the next best thing. They cost a lot per case for what you get. But it's obviously probably easier for somebody who's just starting out, but they often don't work in the pelvis. We have engineers in-house, so we actually have an in-house system that does 3D models and does 3D cutting jigs. So it's really easy for us to work with those group. I know there's a lot of hospitals, or some hospitals have that. Like, I know the guys in Tel Aviv, Amir Sternheim, they set up an in-house system with an in-house engineer who does all their cutting jigs and 3D stuff. But there's lots of companies who do it too, right, for people. And, I think for people who don't have the availability of a cone beam CT or can't get a Stryker or Biomet system easily, these are probably the next best thing. And it depends what you have. And there are some cases where one works better than the other. But if you don't have one or the other, you just have to make do. That's the real world answer, I think.
Yeah, exactly. And I think if you're going to use jigs or navigation, then you've got to remember that the bone that you're taking the donor from for the allograft is different size and shape to the bone that you're putting back in. So that means you've got to get a CT of the allograft as well. Not necessarily, but that's the way we do it. We get a CT of the allograft, and that's all additional expense as well. It's not, like Jay says, we pay a standard fee for our navigation. We rent the system, or we buy the system. If you're paying in the UK, it's £5,000 per jig, and that's probably a lot cheaper than North America if you're not making it in your own university institute or whatever. But so they can work out pretty expensive,
I think in North America it's about 10,000. I think for companies it's about $10,000 for cutting jigs.
Yeah.
Like, in-house costs us nothing, luckily.
Yeah. And that's what I say. You need two of them if you're going to do an allograft, and you need a CT of the allograft before. So all in all, it ends up being pretty expensive for us. But it's the right thing to do if you're doing a parosteal osteosarcoma like you showed, which is difficult, or a joint sparing thing. So I'm not denigrating that. It's just the things that some people don't factor into sometimes.
So one question for Jay and Peter is, you built a software that looks like it has been made for the needs of orthopedic oncologists and for tumor surgeries. Now, do you need to make your own hardware for that, or can you use that software with the other navigation systems and make our navigation better with whatever is existing? Like, for example, we are using the BrainLab system with the automatic registration. It's just not designed for tumors. So we have a lot of shortfall on that. So can we use the software that you have developed and still do the navigation with that same system? Would it be possible?
Probably.
I don't know. It's a good question.
So I've used originally with the arrow here was for BrainLab, and I could, if I use fiducials, I could use the BrainLab arrow with a Stryker navigation software and do navigation. So it's a matter of the data communicating with each other, but you can do that. Arrow is now owned by Stryker. So now I can do automatic registration because they changed the optical trackers and calibrated it on the Arrow CT.
Okay.
I think one of the issues is for Jay and Pete, it's been a labour of love, hasn't it? We've been watching this come over the last 10 years, and it started off as a thing to, an interesting project and lots of projects around it. But this is the big problem, isn't it? We are bottom of the pile when we talk to Stryker and whoever are the big companies, and they're never going to make their money back for these big investments off cases, like ours that come across in a while. That's why they want to do it for primary joint replacements, and then it'll be shoulder scopes and ACLs and everything before it gets to tumours. So I think it's beholden on people like Jay and Pete and other people that are doing this great work to try and see if there is a way that we can get it used, and whether navigation is going to be old hat in 5 or 10 years time and it's all going to be something else, I don't know. But this is where we probably all need to work together to try and do stuff like this, isn't it?
Right.
Yeah, I think that our issue with our system right now is it does provide a lot of advantages, but we need an engineer in the OR to actually integrate all the data once we've done our spin to make it work, right? It's not at a point where that happens in the background, just like the system that like David and Lee do, because it's sort of an in development thing. And so we probably ultimately I don't know, we're trying to obviously get to that, but whether we could actually ever get to a point where a company would be interested in like making this easily accessible or easily available or integrated into, I don't know. It's not a big profit item for them.
No.
Yeah, exactly. Yeah.
Market demand.
And like the cone beam CT we have from GE, like they have this big research lab in France, and every once in a while we keep hearing they want us to come and work with them and try and make this better. But then they say, oh, you're the only orthopedic oncology group that has this cone beam CT and is doing this. So I don't know if we really want to do that.
Yeah.
So trauma also uses a 3D fluoroscopy unit as a CT. So that's I tend to scavenge from a lot of other services at times as an orthopedic oncologist. And so spine, typically using it, as well as ortho trauma, will typically use it as an opportunity to collaborate and possibly help each other out in your respective departments. That's an option and a way to look at things as well. I don't know. I spent a lot of time figuring out how to get things and scavenge and do things like that. Obviously,
that's great for us, isn't it? But if you're in Cebu, or you're in, lots of parts of the world, we're very blessed with some of the equipment we've got, isn't it? And that's where software type things may be more accessible to the rest of the world. That doesn't necessarily require big, infrastructure things. And I don't know, maybe we should try and get a working group and everybody come up with some ideas and do it all together and pitch it to a company rather than all working on different things individually,
Right.
I think that's a great point.
Yeah.
Okay.
I think the best suggestion is, I think we should all get together, make that working group and and get a system that works for us. Get people who are interested to come into it and contribute into it. And I'm sure we can get something done at a reasonable cost on that.
So that's a great idea, and that's maybe something that we could do during the ISOL's meeting. Have a, session, or have a, kind of an afternoon where people get together and kind of bounce off eyes, or at least get everyone's emails together to start that work group. Since I'm sure everybody on the call will be in Brisbane in October for the annual ISOL's meeting. It's now about 18 after the hour. I want to thank Dr. Agarwal for organizing a great and very interesting seminar. I want to thank Dr. Lee Joyce, Wonder, and Dr. Ferguson for participating. And I want to thank Dr. Zumaraga for helping and setting this up. He is definitely my stalwart co-pilot in all these webinars. So I want to thank everyone very much and have a wonderful day, evening, afternoon, and looking forward to seeing everyone in October. Thank you so much.
Thank you.
Thank
Thank
you,
you.
guys.
Bye.
And-
Right.
Thank you very much, everyone.
Nice seeing everyone.
Manesh, great job. That was really interesting.
Thanks, Val.
I appreciate you setting it up.
Recording stopped.